Welcome everyone to this Lifebox virtual town hall on a clean cut results, a path to success. My name is Sanais Bitao. I'm Lifebox's head of programs for East Africa. And before I hand over to our chair today for this session, we have some few formalities. The first one is this session will include 15 minutes of panel discussion, followed by 30 minutes for an online question and answer, which is from our participants. If you have any questions, please put them in the Zoom chat. Our panelists will be answering those questions throughout the session. And also, please note that we have French and Spanish interpretation today. To listen to this event, please you can choose the Zoom in your Zoom screen at the bottom on the globe sign, which preferred language that you want to follow us on. And if you have any difficulties, please again write us in the chat box. And the webinar today will be recorded in English, French, and Spanish. If you miss it, we'll post it online after the session, and also we'll email it to you along with any resources that are mentioned in between the discussion. And now it gives me enormous pleasure to introduce our chair today, Dr. William Berry. Dr. Berry is a Lifebox Global Governance Council member and serves as the strategic advisor to the Chief Medical Officer and as Associate Director of RNA Labs. In 2012, together with Atul Gawande, he co-founded RNA Labs and served as Chief Medical Officer for its first 5 years. He also created the lab's implementation platform and served as its director. He began working with Dr. Gawande back in 2005 and initially served as a Boston project director of the WHO Safe Surgery Saves Lives program. Dr. Berry is a retired cardiothoracic surgeon now with interests in patient safety and implementation in healthcare. Dr. Berry, thank you so much for sharing this today, and I hand over to you. Thank you.
Thank you so much, Sanaya, and it's such a privilege to be able to have you all with us for the next hour and a little bit to talk about things that are so important, particularly given the status of the world right now, which I'm reminded of by just scanning all the pictures and seeing into people's homes, something that would never have ever happened in the past. We're going to talk today about some about Lifebox and quite a bit about Clean Cut. My link to Lifebox was through work that I did, which is not in my intro, on the WHO surgical safety checklist. And just to remind everybody, Lifebox actually came as a direct result of the checklist, which had a courageous item on it that asked that pulse oximeters be used whenever anesthesia was administered to a patient who was going to undergo surgery. And when we got done, it was clear there was a gap, that we had asked for people to use a piece of equipment that didn't exist in many parts of the world, and a tool set up founded Lifebox, which has taken on as its mission not only to try and close that gap of pulse oximetry around the world and improve anesthesia care, but also to improve surgical care more broadly, and Clean Cut sprang from that. When we made the WHO checklist, I still remember it to this day. Dr. Gawande and I talked before we ever went over to Geneva, and Dr. Tom Weiser, who's on the call with us, was part of those discussions too, about a single item checklist emerging from all the work that we were doing. And it was going to be perhaps focused on giving preoperative antibiotics to prevent surgical site infections, because it became clear in all the research that surgical site infections were a major issue. And we went with that idea in our heads. Obviously, we emerged with something that I think it was more complex, if you will, than a single item, but also something that could contribute to improving the safety of surgery globally. And Clean Cut came a handful of years ago as a Lifebox effort to be able to reduce surgical site infection, doing all those other things that the surgical safety checklist implied needed to be done, but really didn't have a clear path for how to get them done. So that's what we're going to talk about today. We're going to hear a lot from people who are in the field, who have actually experienced the Clean Cut program, and we're going to hear from the people who made it and have refined it to where it is today, because it's an incredible body of work. So is Dr. Hassan Mohammed with us or no yet?
Not yet, but hopefully he will be with us soon.
Okay, so because our time is so tight, we'll hold his spot, and eventually we'll be able to move and bring him back in. Well, he may get there by the time I'm done with all the introductions. So it's a great honor to have him with us today. You can read that he's a public health specialist. He works at the Federal Ministry of Health in Ethiopia as the Director of Health Services, and he's worked as an advisor to the Ministry of Health on public-private partnerships in health, and as a national program officer for the health system, strengthening for the World Health Organization, for the WHO. All right, the next slide. This is my friend, Dr. Abebe, who I have never met in person, but have had the privilege of being in virtual rooms with multiple times. Professor Abebe is a general and thoracic surgeon and dean and deputy vice chancellor of academic research affairs at the University of Global Health Equity, Kigali, Rwanda. He is senior advisor to the Ethiopian Ministry of Health in its flagship global surgery program, Saving Lives Through Safe Surgery, or SALTS. It's great to have you with us today, Dr. Bebe. Jared Foster. Jared Foster is, I have had the privilege of watching Jared advance in his career, and he is nearly at a landmark in finishing his surgical training and about to go out into the real world of being an active, hopefully, general surgeon. But Jared is a general surgery resident now at Stanford. He completed a 2-year fellowship with Lifebox in Ethiopia, developing the Clean Cut program. Jared is lead author of the recent publication in the British Journal of Surgery on the results of Clean Cut. Dr. Netnail, okay, I'm going to mess up his last name for sure, Gebayehu, has extensive experience as an operational theater manager and surgical ward manager at St. Peter's Specialized Hospital in Addis Ababa, where Clean Cut was piloted. He's also a Lifebox fellow and continues to work as an assistant clinical service advisor at St. Peter's. Dr. Tito Ngusi Mamo is an associate professor of pediatric surgery and a consultant general and pediatric surgeon with experience in Tikur Anbesa Specialized Hospital. Dr. Mamo worked on the implementation of Clean Cut and has recently been appointed the Global Clinical Director at Lifebox. Nicole Starr, who I've also had the privilege of knowing for the last few years, is Lifebox's senior fellow and a resident in general surgery at the University of California, San Francisco. Based in Addis Ababa in Ethiopia, Nicole works on the development and implementation of Clean Cut. It's great to have you with us this morning, Nicole. Dr. Weiser. Dr. Thomas Weiser is an old friend. I first met Dr. Weiser when he was a general surgery resident, actually, doing his fellowship back in the middle of the first decade of this century. Dr. Weiser is Lifebox's consulting medical director and a general and trauma surgeon, a surgical intensivist, and an associate professor of surgery at Stanford University Medical Center. From 2006 to 2009, that was when we were working together closely. He was part of the World Health Organization's Safe Surgery Saves Lives program, which helped to develop the surgical safety checklist. All right, we cannot forget the partners who have worked with us closely to set up and do all of the work that it's taken to bring the Clean Cut program to life. You can see that they're listed here: Assist International and the GE Foundation and its Safe Surgery 2020 program. All right. We also have to express deep thanks to the Ministry of Health of Ethiopia. The work in Ethiopia would not have been possible with the leadership that the ministry has given from the top. All right. I'm not going to read every single institution that's been a part of this work, but you can see that there have been multiple partner hospitals on the ground across Ethiopia. Again, the learning that's taken place and the program as it exists today would not be possible without the hard work of the frontline clinicians and administrative staff of all of these institutions. All right, now I've got to bring my notes out. So I was going to apologize at the very beginning for using notes, right? But this is a person that helped to develop a surgical safety checklist, so I'm not going to apologize too much. My fear is I will forget something. So I'm going to refer to my notes multiple times and you're going to see me do that. I guess I will not be embarrassed. Normally I would be, but I won't be today because this call is just too important and I don't want to leave something out. So this slide is to remind me to thank the Ethiopian Association of Anesthetists, the European Society of Anesthesiologists, the Society of the Surgical Society of Ethiopia, and the European Society of Obstetricians and Gynecologists. Unfortunately, I cannot read the text, but I'm told that's what it translates to. All right. A quick reminder again, at the bottom, it took me a little while to find it. There is a globe on my screen. It's at the bottom and maybe on the top on yours or on the side. There is a globe there that you can click on if you wish to listen to this interpreted into French or Spanish. Or you can listen to the panel discussion in English. And now to the panel discussion, the most important part and the heart of this call. I do not think that Dr. Mohammed is with us yet. I don't see him. Oh, there he is.
Yes, he is with us.
Fantastic. Oh, thank you so much. So, Dr. Mohammed, welcome to the call. I hope you didn't miss your introduction, but if you did, we've all been looking forward to engaging with you today. And thank you so much for all the work that you've done at the Federal Ministry of Health. It is added to the development of Clean Cut and certainly to the richness of the learning and the work that's been done on the ground across Ethiopia. So I'm going to start out by asking you a question, and I'm going to end up by asking you a question at the end of the panel discussion. Right now, I'd like to hear from you about how Clean Cut fits in the current strategy of the ministry around safer surgery. Are you there? I can see you. I can see your mute button go away and the mute button off. You're on.
Yeah, I'm on actually. Thank you so much. And sorry for joining a bit late because I had difficulties in opening the Zoom. So can you repeat the question that you raised?
Oh, absolutely. If you could share with us where you think the Clean Cut program fits in the Ministry of Health's current plans for improving the safety of surgery in Ethiopia. Does that make sense? How does it fit today?
Yes.
How do you think it fits today?
Yeah. Yeah. You know, we have the 5-year strategic plan to improve the surgical services in the country. And Clean Cut so far, they have worked closely with us, and they have provided us technical supports in improving the surgical services. They have also provided us some equipment to improve surgical care in the hospitals. And it's in line with the minister's strategy to improve the surgical services.
Before Clean Cut, did you have, just a little follow-up question, before the Clean Cut program was developed, did you have specific work that was focused on reducing surgical site infection? Or has Clean Cut kind of evolved right along with your strategy?
Yeah, um, there might be some scattered activities at facility levels, but there was not as such a organized way of handling the surgical site infections in the facilities.
Thank you so much. I'm going to come back to you again at the end, and I'll ask you my question now so you can think about it. If you were to cast far into the future, out past your 5-year strategic plan, how do you see Clean Cut in that future? But don't answer it now. I'm going to come back and ask you that. And now I want to move to Dr. Weiser and have him talk to us some about the Clean Cut program to give us an overview of it. Tom has Clean Cut's name, the Clean Cut content, the Clean Cut program, the design is all a product of the mind of Tom Weiser. And what's happened since then, obviously, has taken a huge team. But there wouldn't be, in my personal opinion, there would not be a Clean Cut if it weren't for the imagination and the dedication of Tom. So if you can share some of your thoughts about Clean Cut with us, Tom, that'd be great.
Well, thank you so much, Bill. You're being overly generous. This was a huge effort from so many people. So I was but one of many people who helped this development over the course of its lifetime and beyond. So Clean Cut really came out of work from Lifebox that recognized that we had this incredibly powerful tool in a checklist that could absolutely reduce complications and mortality from surgery. But in fact, the challenge was really one of implementation, that many of the items on the checklist, while very concrete standards of care, also had very unclear mechanisms of implementation and adherence. So, for example, things like the appropriate timing and administration of antibiotics sound simple to put on a checklist, but are actually very complex to implement, especially if the processes of care are misaligned. And those can be misaligned for a whole host of reasons. And so one of the reasons that we developed Clean Cut was to develop a mechanism to help and support frontline providers actually implement elements of the checklist. And we chose surgical infections for a number of reasons. The first is that surgical infections are a major, if not probably the major killer of surgical patients. Surgical antisepsis and infection prevention has been a cornerstone of surgery since humans first set knife to skin, and being able to control and reduce infection rates is a massive contribution to modern day surgery. The other piece is that we actually know how to reduce surgical rates. The problem is that it takes a host of coordinated activities across the entire spectrum of surgery, from the appropriate use of antibiotics to the assurance of asepsis and aseptic techniques, to the appropriate decontamination of skin, to the routine counting of swabs and sponges during surgery, to the assurance of instrument sterility, and even to the appropriate working of a team. And so we developed CleanCut as essentially a package of interventions that would identify, and we identified 6 core principles of surgical infection prevention, and then a mechanism to implement those in hospitals wherever they were around the world that were accomplishing surgery. And so those 6 core factors, and we'll talk about those a little bit more in the next, Dr. Forrester will talk a little bit more about those 6 specific items. But just to reiterate, those are the appropriate antisepsis of skin, so the appropriate washing of skin in surgeons' hands, the appropriate sterility or the confirmation of sterility of instruments, the maintenance of a sterile field during surgery, the appropriate timing and administration of antibiotics, the routine counting of swabs during surgery, and the use of a checklist to improve teamwork and communication. And that all came out of work that we've been doing for the past 10 to 15 years, and I'm delighted to see that it has evolved so far. Thank you.
Thanks so much, Tom. I think now we'll move to Professor Abebe and to Jared, because their work has been so intertwined over the years, to flesh that out just a little bit. In your eyes, Dr. Abebe, how have you seen the program evolve since you were first involved in it?
Thank you, Bill. Good morning, good afternoon, everyone. It's so great to be amongst all of you. I still remember the very first breakfast I had with Jared and Tom, I think about 7 years ago, when we discussed about scaling a relatively smaller CleanCut program in a smaller town called Jimma to the capital city in Addis. And then we thought, within a couple of years, we might even go national. So that's what actually happened. The project team started the program in Jimma, the Jimma University Hospital. And based on the success they had, not only just a success, but the hidden truth that was uncovered there, the mortality, the morbidity, the faults in the surgical process. We thought this might be something the country can learn from, can really benefit from. And that time coincided with the launch of the SALTS initiative, the Saving Life Through Safe Surgery initiative at the Ministry of Health. And we decided to bring this project to the 2 of the bigger hospitals in Addis, the Black Line Hospital, the Togoran Bessa Hospital, and the Minilik Second Hospital. The results were phenomenal. We could clearly see that this work was really instrumental in, number 1, identifying the burden of surgical infections we have. Number 2, in identifying, in clearly showing to the world that without investing too much, without too much innovation, just by restructuring what is already there in the hospital, significant results can be achieved. Then the work will then spread to 2 other hospitals. Then I'm hoping it's going to be national now. So the key factors for the success, how it evolved is because, number 1, it's such a pivotal work. It was concentrated on one of the commonest cause of death after surgery, surgical infection. The government had a huge focus on SSI prevention reduction. And number 3, because of partnerships and friendships among us, the project members. Jared, if you have something to add to that.
Yeah, no, it's great to see everyone together. It's been, 5 years in the making or so. Echo what Professor Abebe said, that it kind of grew organically after our first involvement in Jimma. And that's kind of where we learned a lot of good lessons. It was a challenging time in the setting of the surgical program moving to a new hospital, and also some ongoing political challenges. But I think out of it, we formed a very tight network of team members of both anesthesia, nursing, and surgery, and really learned lessons on how to implement it in an effective way at the Tikurabesa, Menelik Hospital, and others to really drive program change.
Professor Abebe, before I let you off the hook right now, can you give us your perspective on the importance of having the Federal Ministry of Health support for this work? You're muted.
Yeah, thank you, Bill. Thank you for the question. I would like to really acknowledge the presence of Dr. Hassan Mohammed with us today. It clearly shows the fact that the ministry is committed to this program. He devoted 2 hours of his time to join us. And Dr. Hassan, it's so great to see you today. The ministry injected leadership and direction to the project. Once the ministry accepted the fact that this is a great project to implement in Ethiopia, it dealt with surgical site infection, they embraced it. Regular follow-up meetings, regular check-ins, support, linking the project team to the different hospitals, the regional health bureau leaders, was the task of the ministry. So without the ministry, I really doubt that such a result would have been achieved. And this has also indicated, I'm sure there are panel members from the other parts of Africa who are interested in the CleanCut project. This is the way forward. Without central leadership, central ownership by the government, by the Ministry of Health, just like what Ethiopia and what Dr. Hassan and his department did, success would be very difficult. So the ministry's role was significant.
Yeah, I think everybody should be aware that back when Tom and Atul and I first started this work, and we started to talk about how to spread it globally, we recognized in the very beginning the pivotal nature of the ministries of health around the world. And I'll be honest with you, it has been a difficult journey a lot of time to get the ministry to understand the importance of the work, but when they do, their support has been invaluable in making this kind of work actually move forward. The ministries play such an important role. You know, I think we all have to recognize they have multiple priorities and huge populations to serve, and they're very, very challenged. But in this work in particular, their involvement and commitment is absolutely critical. So now I want to spin it a little bit and talk about something that the team should be very proud of, and that is an article that was recently published in the British Journal of Surgery. And Jared, I know that you were the lead author on that. So I wonder if you could share some of your thoughts about the article. And I'm not going to read the title because it's like 5 sentences long, but this is not an Atul Gawande title, by the way. He would not approve. But the article is wonderful. Can you share some of your thoughts about it with us?
Yeah, definitely. I'd be happy to share the results on it. And mirroring some of the Ministry of Health, I think the other comment goes to show that this doesn't happen without partnerships. And so the people you're seeing on the screen today, and importantly, Prof. Abebe, Dr. Tetana, Dr. Tom, of course, Nicole on the ground, and Dr. Nathaniel, have really driven the work of this whole project. So I'll just do a quick little screen share here of some of the things. I don't want to bore people with slides, but it's helpful from seeing some of the results of the work. So this paper that we described, hopefully, let me hold on, if I can get this right here. There we go. So this is looking at our CleanCut results from our first 5 hospitals in Ethiopia. And as Dr. Weiser mentioned at the beginning, we're trying to improve adherence with 6 basic quality indicators for infections. And 3 of which are just on the surgical safety checklist itself. And that's making sure antibiotics are delivered at the right time, making sure we're doing standardized gauze counts so that we prevent against retained surgical items, and that way, and also that we're confirming that instruments are sterile that we're using. Then 2, just inherent to safe surgery in general, that's making sure we're using the appropriate skin preparation of both the surgeon's hands and the patient's surgical site, as well as sterile gowns or sterile field. And then lastly, a surgical checklist. So to do this, we operationalize all these definitions so that we'd have trained nurse anesthetists in the or nursing theaters to really record what was going on in an operational manner. And then we would follow these patients through over 30 days for their outcomes in terms of surgical site infections, hospital length of stay, and the overall outcome. What we found over almost 2,200 cases, so we did about 370, a little bit over that, were in a baseline period of over 6 weeks, and then we would follow those out to 6 months. And we found that, at the beginning, out of those 6 indicators, the most people were meeting it about 2.9 out of the 6. And at the end, we found about 4.5. So we saw a significant improvement with adherence to some of these infection prevention markers in the operating room. And this is a spider plot on the screen showing kind of that improvement from before that solid blue line to the dashed red line in the outer. And I think the main thing is, yes, we can show some improvements, but really, did we have an impact in patient care? And so when we looked at the relative risk of postoperative infection, controlling for some of these variables, we found about a 35% reduction in the risk of postoperative infections after the implementation of Clean Cut as a whole package. And then importantly, we saw an association too with the more you adhere to some of these standards, the better off your patients will be. And we saw a 46% reduction in risk of postoperative infections when we compare those that met over 3 of these adherence versus those that only met 0 to 2. It's kind of a quick run through on this kind of important work and over 2 years of data. But I think the main things is that we can drive change, and I think the real meat of it is how do we do it. And one is having a great team and having all these people together with a common mission. And then 2 is we kind of adapted and evolved this program over time to really incorporate learning points from kind of some business techniques to try and drive at the process changes. So it's a lot easier to check a box yes or no, but really, how does an instrument get to the operating room? How is it actually getting clean? What materials are available? And so we use these process maps for each one of these 6 processes to really highlight and get together as a team, where are we right now? How can we improve upon it? And then how can we really disseminate these findings to really make change last? I'd be happy to talk about any of those parts further.
Thanks so much, Jared. I think we can come back at the end if people are interested in more details, and we should probably move ahead to get the reflections of Dr. Tahatna, who I know, there you go, who I know was involved with implementing this in the pediatric surgical service and more broadly in the surgical service at the hospital where she worked. And now obviously she has a different role going forward. But I'd love to hear your reflections on what it was like to be on the receiving end. Dr. Weiser and Dr. Forrester obviously were at the time were helping people implement, but you were the one that was being helped on. And if you could tell us a little bit about that experience, what it was like, what you learned, and that kind of the important messages you took away.
Thank you, Professor Berry, for this asking for this question. So as been already said by my colleagues, the Clean Cut implementation aim is not only resulting in decrementing the infection of post-surgical patients, in addition, it is targeted to adhere for the specific standards in surgical patients. So fortunately, our CleanCut project showed us there is a significant improvement with both compliance and the reduction in SSI by simply adhering to the standards and without demanding for additional resource or human resources. So as a surgeon, when you see your patients are complicating with simple intervention, you feel somehow like you feel sad, you feel devastated, and you don't want to see your patients suffering from those kind of complications. So as being a recipient for this kind of intervention, I was really happy seeing this kind of result for my specific patients, and to see my operation theater to adhere to this kind of specific standards. In addition to the infection prevention standards, our use of WHO checklist was not that much significant in most of the hospitals. We work on this project, but through time, by properly involving the stakeholders in the meeting and showing them the results, the use of WHO checklist also improved. So in addition to SSI, there is also even if we didn't study that thing, there is also an improvement in the overall complication of patients once we use we properly use WHO checklist. So by this is the significance, not only by statistics, but clinical significance was much more important for us, and we saw those on our patients. And the ministry's involvement, the ministry was believing in us that this thing will bring a significant change for the country, and our hospital admins were part of us. We saw significant improvement to our patients, and definitely since our hospitals are an example for low and middle income countries where there is a limitation on resources, then this thing will be easily implemented to other countries with the same scenarios without significantly demanding additional resources. So there was significant improvement to the surgical service concerning to especially surgical site infection. Yeah.
Thank you so much. Thank you so much for those reflections. I think, you know, the work that you've done so far is just admirable. I picked up early on in your remarks, you used the word simple, and I'd like to expand on that for just a second, because even though this work is actually quite simple in concept. I mean, Tom talked about 6 things, and 6 things are 6 things, but translating, I think what you know in your heart is taking these 6 simple ideas and actually changing the way that people work together and their behavior and the way they work together as a team is a little more sticky than simple. So a simple idea, but it takes people working really hard to actually implement this. So I know that you're working together now closely with Nicole, and are thinking about how to take this work forward. So what's happened since not since the paper, but what's happened since all that data was collected for the paper to make this program maybe a little more simple? Nicole?
Thanks so much, Bill. And it's really amazing to finally have this panel together after what feels like has been a lifetime of work and accomplishments at these hospitals. We're really proud of what we've done. So it's really exciting to be able to talk about it. I think, you know, we started out with a really strong program structure that we knew was rooted in evidence-based practices, and the strength of the program shows in the results that you see from the 5 pilot sites. But of course, as we moved on to implementing CleanCut at more additional hospitals in Ethiopia, we had to learn and evolve and grow and change the implementation strategies that we used so we could continue to improve. So I wanted to sort of get a little bit into the nitty-gritty of program implementation and talk through some of the specific changes that we sort of grew into as we've implemented CleanCut at the additional 5 hospitals since the pilot data collection ended. So first is around data collection. Of course, we needed at first to pay for data collection because it was really important to have quality and complete data so that we could show the success of the intervention. But as we moved on into implementing this in sort of a wider national level, we had to shift away from paying for data collection. And we feel like this has actually allowed for a little bit more institutional buy-in into the program, rather than having just a few data collectors charged with a pretty big task of observing a lot of operations and maybe rounding additionally on all patients. This allows us to whole OR team effort where everyone is responsible for doing their little part. And that really goes into the whole sort of ethos of Clean Cut. And so we feel like that was helpful. We also put some emphasis on this mentor-mentee relationship that was sort of naturally occurring in some facilities. So for example, St. Peter's and Fiche, which were part of the pilot study, are actually part of the same referral network, the Ministry of Health referral system. So allowing one to be the mentor for the other and come with us on site visits, participate in action planning meetings, that really helps strengthen those relationships that were already supposed to be existing in this referral network. And we hope that will have more of a lasting impact. We started to put more of a priority on operating remote, and now we really emphasize that role as basically the person who's the coordinator of all the OR processes and has really become one of the institutional leaders now of a Clean Cut program at any hospital. And then finally, we built this data entry and analysis platform using DHIS2 software, which has been a labor of love, but allows for the data to be cleaner, to be visualized automatically using a dashboard, so that hospital teams can just log in whenever they want, view their progress in real time, and view their improvements. So those are just a few of the specific changes that we grew into over time. I don't know if Tito wants to add.
Yeah, thank you, Nicole. You already said it well. So as Dr. Berry were already saying, there was significant challenge while we are trying to implement all these things throughout those hospitals. So fortunately, we learned a lot from all the hospitals and we improved dramatically since its initiative. So the most important thing was whenever something like especially quality improvement idea is wanted to be implemented, we have to start from the hospital admin to the staffs which are working on those specific areas to be involved together. Otherwise, if they are not buying the idea, all the staffs are not buying the idea, then implementing it will be very difficult and it won't be there. So on the first hospitals, even though we have good data collectors, clinical lead in the hospitals, while we are taking baseline data, even after implementing the intervention. So regular meetings were very difficult to get all the staffs to be involved, especially the admin side. So whenever we need to improve some things, it was challenging for us to convince the admin. So showing the results and engaging them in each and every aspect, communicating formally and informally, helps us for them to be engaged with us and to understand the idea of this specific initiative, and by seeing the results, they were interested to be involved with the ideas. So through time, involvement of these administrators will help us to come up with the specific things we want to improve through time, especially when it comes to sterility area adherence. So we want the gowns and the dress to be hold free. So we want to have somebody who can maintain those things in the hospital. So these things will be achieved if the administrator is convinced by the idea. When it comes to team engagement, we want somebody as OR manager specifically dedicated to work with all the OR things, not only the nursing thing, not only the, but organizing the whole thing and as a representative as OR manager. So through time, while we are continuing to escalate this Clean Cut project, so all the new hospital starts to have their own OR manager, which helps us to implement it relatively easier than the previous hospitals. So through time, there is significant change, but the first 5 hospitals were a learning period for us to improve throughout the process of having this project. Yeah.
Thank you. Thank you so much. I think, Dr. Nail, I know that you have a lot of practical experience in working with OR staffs and trying to, trying to do the things that we've already heard about. That, again, having a lot of practical experience with implementation myself around the surgical safety checklist. It's a beautiful, simple idea, but making it actually happen can be a huge challenge. Could you share some of your experiences and your thoughts around what it's been like to actually, take clean cut from all of the manual and all the ideas and actually having people do it?
Thank you, Will, and I'm so glad to see all of you here, and I'm so honored to be part of this thing. I'm gonna take you back for a while. I'm not gonna be part of the Lifebox because our hospital and Lifebox were introduced in one meeting where Nicole, Professor Abebe, and Sandy were leading, which was an introduction for what Lifebox has been doing and about the clean cut. So I remember taking notes on Professor Abebe's presentation, and I still have the notes. So when I was introduced with clean cut in Lifebox team, I was a ward manager rather than an OR manager. So St. Peter has been a center for quality improvement in different situations, but surgical site infection was not one of it. So fortunately, in the development of the Ethiopian health system with SALTS, Professor Abebe have been mentioning it earlier. So there have been different checklists and assessment tools, and also key performance indicators, which are ideally supposed to monitor and follow these operation theater practices, including the safety checklist and other or environment practices which lead to safety of patients and also the practice of decreasing surgical site infection. So the problem was the integration between these standards, tools, and also the monitoring equipment and guidelines with the actual practice where the OR staffs and the surgeons, anesthetists, and also the other OR supporting staffs, while they are practicing, whether they are doing it in the right way or not. So as a ward manager, I have been having lots of problems with increased surgical site infection and also reporting these key performance indicators saying there is no surgical site infection, we have 100% safety checklist usage and lots of other things. So for me, it was a good entry point when Lifebox came to us because we have no idea how to start. And that has been the practice wherever we duplicate the system after the data and the results that we found, which shows CleanCut is a good quality improvement idea to change these practices. But it shows you where to start actually, because the documents are organized in a way that it's on the ground rather than the guidelines and documents which everybody knows. The surgeon knows when to give the antibiotics, anesthetists know what to do while doing some anesthesia stuff, and the scrub nurse also knows how to do it. But the problem reaches where there is a communication between them, because the scrub nurses only have a chance to change or to do this safety practice when they are in the OR. So they have no control over how the instruments are processed, how the drapes are coming to the OR, and how the antibiotics are given in the wards and so on. And the surgeons also will be introduced in the other systems whenever they took their patients to do this operation. So that was a big challenge, actually. But not only a big challenge, but that was the biggest complete. It creates or makes a complex system. So when I introduced with the Lifebox team and the CleanCut idea, it makes most of the things clear and easy to implement. So next on, when we have the process mapping with Jared, everything was messy in St. Peter, and that was a good insight for me. Then that's when I changed it from I was an OR manager and a ward manager, because most of the time the ORs are given for head nurses, which will be assigned in the OR, and they have no communication and no control over any activities with the anesthesia, the surgeon, and also the ward. So we took that assignment of creating a team which will be incorporating anesthetists, surgeons, or nurses, and also any practitioner there who will be together. There will be a team called a quality improvement team for the surgical environment or the OR environment. So then that resulted in changing and monitoring all activities that are stated previously by Jared, which are part of the clean cut interventions. So the basic idea, or the basic way of the basic tool that created a good compliance in our perioperative standards compliance in our program is giving ownership for the hospitals and the team. So we don't say that Lifebox came here for you to create some miracle syndrome. We don't do that in any of the practice that we have been, and also in the practice that where I have been on our manager in St. Peter. So we just give all the things to be changed, all the standards for the team, and the team will decide on what to do. We just remind them this is a practice which has a good data, which has a good evidence in decreasing whatever we say, be it surgical site infection, be it surgical complications, and so on. So we will just give them, we'll remind them these are the standards, and what shall we do? How do you think your practice will be modified? And then they will be following their team. Each team will have its own responsibilities while we are doing our rollouts, action plans, and different meetings. So giving ownership is, I think, the key and important role that we made in our change and in our introduction of the program, and that increased the compliance throughout the 6 months of the time that this Clean Cut QA project is implemented in each hospital. And I think Nicole has lots of things to add, and I will leave the place for her. Thank you.
Thanks, Nati. And I guess since my, first day arriving back to Ethiopia as the Lifebox fellow, Nati and I have been basically side by side the whole time. So we've gone through all the headaches and the triumphs together. And I agree with everything that he reflected on. I guess the only thing that I wanted to sort of emphasize is this notion of culture change, which is difficult to measure, and it's sort of this like loose, imperceptible transition that happens at some point when we're implementing Clean Cut. But I think Nati would agree, and Jared would agree, that we first engage with the hospital, it's always a challenge. The data is questioned, you're banging your head against a wall, your little core team of Clean Cut that's trying to show these are the gaps, these are the changes that need to be made. You're just sort of, pushing. And at some point, there's this transition where you feel that culture change happen at the hospital. And all of a sudden, the hospital team themselves are starting to ask more probing questions. They're starting to sort of interrogate their own data. They're proposing change ideas. And that is such a cool moment to witness. And that's when you sort of know that the program has taken hold and that it's going to stay and perpetuate itself. I remember sort of experiencing a moment like that with Nati, actually, when we were at St. Peter's. And he started sent me a photo of a whiteboard that he was making himself to count gauze and everything, and cutting and pasting little labels on the whiteboard. He went out and bought this egg timer so they could time the number of minutes that instruments were soaking in the solution. And when I saw Nati sort of just come up with these ideas and just take the initiative to go make a change, it was this is the moment that I know the program is going to stay at St. Peter's. So seeing that happen at every hospital is very inspirational.
Yeah, I have had the opportunity again to reflect on a lot of implementations around the surgical safety checklist over the course of the last decade. And I don't know if it translates well into any of the languages, but all of a sudden people just get it. They understand what it's going to take to make the things actually happen. I mean, I think, Clean Cut is beautiful in that, and Natty said something really important in that it tells you where to start. I can't tell you how many hospitals I've watched struggle because they don't know where to begin. They're so overwhelmed. I mean, Natty, you mentioned, 50 different things in the last 5 minutes. They're so overwhelmed with all those things that need to get fixed or changed that they basically become paralyzed. And Clean Cut gives people a place to start. The other thing that I think is so important, and I don't know whether you guys agree or not, it gives them a way. It may not be the way. And just like you said, Natty, in your hospital in St. Peter's, it may have been a different way than it was at another hospital, right? They needed their own way, but at least it gave you a way, right? So you have a path and now you have a way. And then, like you were saying, Nicole, all of a sudden you can walk in one day and it's happening. And then, so I'm supposed to ask people about what they thought was the biggest challenge, but I'm going to tell you what I think is the biggest challenge and hear you reflect on it a little bit. And that is keeping it going. I think making this change, and, when you said, Natty, use the description, a 6-month period, right? Well, what happens when the clock runs out? And if I go back to St. Peter's 6 years from now, am I gonna, like so many of the things the WHO has done, am I gonna go and see a poster, dusty old poster hanging on the wall someplace? Or am I gonna watch people living the change? So tell me about your reflections on, people call it sustainability. It drives me crazy because it's just, keeping the work moving forward. How do you do it? What do you guys think?
Okay, that's actually most of the biggest problem in every program that I have been installing and also practicing throughout my career, even in growing from this ward manager to now as a medical assistant, assistant. So that's actually one of the things that we have been working on throughout all the growth of Lifebox and the Clean Cut while we change hospitals and so on. So for especially when you come to St. Peter's and when you actually see the practice of this safe surgery in the OR, as I have been saying initially, starting from 2014, the safety checklist implementation when SALT initiative were in Ethiopia, and they have been there, either on the cloud, you can say it, or I don't know, it's in some mysterious way they have been practiced. So as I was a resident while Jared was installing this Clean Cut in Jimma, and honestly, I have no idea of this checklist. I was a resident, but I have no idea what it was. I saw some people practicing it. I don't know the benefit. So the problem that we picked was, we were, or this checklist was given for the hospitals in the system. It was introduced into the system as an obligation and as something which was not actually, again, the pupils or the working staff's acknowledgement. And they have no idea why this was started and how do you practice this thing if you have no idea. You can go all this through these six systems that Clean Cut have been working on, and you can ask people, why are you not using timer while you are soaking instrument? Why are you not monitoring? You can ask the surgeon. If you were asking the nurses that this is the reality of this instrument is kept, and do you confirm it? I mean, do you see it with the nurse, or do you leave it for the nurses or the other stuff? And most of the surgeons, you surprisingly will see them answering, saying like, I mean, I don't know. They have no idea even how to check it. So one of the things is we start from the lowest point of giving them or suggesting them and making them know these are the standards. So once people start to practice on these standards and seeing the change, one thing for sure you will be surprised to know is it will make life easy. So people don't want to be like, don't want to sophisticated environment. I mean, this safety checklist, if you know the practice and if you know the benefit, that makes your life easy, and you'll show them that it is giving you a decreased surgical site infection. The ward stay for the patient is decreased, and most of the works in the OR becoming so smooth. You won't lose instruments in the middle of the surgery. You won't have any problem regarding administration of antibiotics. You won't be at least confused if the patient receives antibiotics or not, because you're going to be in the OR. It's going to be a new phase. So people start to practice it, and they will see the change. The change is not for the patient's decrement in the surgical site infection, but the change in the practice and the teamwork that they will find it in their ORs. So once you leave them, you'll not be needed there. I mean, once I established this system in the St. Peter's OR, I was not needed. People will practice it because it's easy for them. It makes life simple, and it's the right way of doing it at the end of the day. So I think this is one of the biggest achievements that the clinical program has.
Thank you so much. Do you have anything to add, Nicole? I mean, that was a beautiful explanation of building it in as a way of sustaining it.
Yeah, of course, Nati sort of encapsulates all the ideas very eloquently. I don't have a lot to add other than we have started to look at this actually quantitatively, and hopefully this will be the topic of another webinar in the future. But when we do go back to some of the hospitals, 6, 12, 18 months after they finish the program, we have seen that the changes they made persist in most areas, and in some cases even continue to improve. So that's really exciting confirmation for what we suspect is going on at the hospitals after we end our engagement together.
Yeah, to me, that is a mark of a well-done implementation on the part of the hospital, that you can go back and the practices become self-sustaining. That's absolutely remarkable. So I need to shift gears a little bit because time is short and precious. I'm talking to you from a room in my house, a house that I haven't left for any period of time except to go shopping or to visit the doctor or whatever in months now. This little teeny particle has changed my life. And from looking around at many of you, I think it's changed your lives too in very significant ways. Nicole and Natty, can you reflect or tell us a little bit about what's COVID done to CleanCut? How has it affected the ability to implement or, the work that needs to be done? Because the surgeries go on, right? The problems persist. There's still surgical site infections, and now there's this monster out there. So thoughts on COVID and CleanCut?
So I think, COVID, as with many things, has been sort of a mixed bag for us and CleanCut. Of course, logistically, we needed to put a pause on the program activities because resources had to be mobilized to respond to COVID wholeheartedly in Ethiopia. But I think it also that infection prevention is more important than ever if you're dealing with a novel pathogen on top of your work to already prevent surgical site infections. And as you already noted, most operations happening in this context are not elective. They're not necessarily appropriate to be postponed. And so we feel that a lot of aspects of CleanCut became more important than ever. We were able, I think, to leverage our expertise around infection prevention and control to create some new and more robust materials around PPE. We utilized our experience in the surgical safety checklist to create a new checklist that was targeted at keeping healthcare workers and patients safe during COVID. So we all sort of mobilized and responded as best we could to shift our focus to meeting the needs where they stood. And I'm sure other people on the call have more to add about that.
Maybe we could talk about it more in the discussion piece, which is coming up in just a second. But before we move there, I wanted to ask Tito if she can share her ideas about the short, medium-term future, given COVID too, of continuing to spread this work, beyond Ethiopia to other parts of the continent, and then eventually globally. So a few thoughts, if you would.
Thank you, Be. So as has been said, since we got a great output from our project, so we want to escalate and also address all low and middle income countries to have the best outcome on their patients with concerning specifically to surgical site infection. So thanks to COVID, in addition to having face-to-face training, face-to-face planning and visiting hospitals for implementing CleanCut, we try to create learnings from remote, online learnings via virtual, and also uploading different documents on our website so that people can see it and read about it and understand it if they want to implement to their hospitals. So all these things are part of our COVID output. And additionally, in collaboration with Ministry of Health, as you know, Ministry of Health in 2016 pioneered the initiative of SALT, or Safe Surgery Anesthesia program, in sub-Saharan African countries. So this CleanCut is also a pioneer agenda for resulting in a reduction of surgical site infection. So as we took a lesson from the piloting and the implementing in Ethiopia, we are now included 5 more teaching hospitals, which has got a catchment of additional primary and secondary hospitals to be part of the next 6 months project for our new CleanCut implementation. In addition, we collaborated with Ethiopian Obstetrics and Gynecology Society to implement this CleanCut specifically to patients with cesarean section in 10 more hospitals. And also, as you all know, we have a lot of fellows with Lifebox, and Lifebox is expanding our service towards the globe. So we are planning to use our staffs and our fellows to implement these CleanCut ideas to Southeast Asia, Central America, West Africa, and also as our regional hub, the whole East Africa. So we start communicating with people from Uganda, Madagascar, Rwanda, Liberia, and Bolivia, India. All the countries are now getting the idea, and we are going to launch soon to involve all these sites. Yeah, thank you.
Thank you so much. That's in such a concerning time, that those are such hopeful words. And it sounds to me like the program is adapting itself to try and continue the work. Like I said, surgery hasn't stopped, and the problems that come with surgery haven't stopped. The needs are still there, but this is just one bigger, even like Nicole said, it's even more important now to do the work. And actually, I'll be honest with you, I think Tom would agree with me here that a lot of this work has helped us deal better with surgery and COVID. Not that COVID causes a different kind of infection, not a wound infection, but it's the discipline that it takes to do this work has helped in dealing with controlling COVID in the operating room and making it safe for the surgeon, the operating room team, and the patient themselves to actually have surgery. So I'd like to circle all the way back to Dr. Mohammed from the ministry. First, to thank you so much. I know your time is so valuable for spending time with us on the call and giving us a piece of your afternoon and evening there. And then to re-ask you that question that I asked you at the very, very beginning about eventually, where do you see CleanCut fitting in to the plans of the ministry around improving the safety of surgery? Because I think this is a long journey.
Okay, thank you so much again for having you all in this meeting. First of all, I would like to respond to the question you raised earlier. You see, the government has been working a lot on improving access to health care in the last decades. And it's only the last 5 or 6 years that the ministry wanted to provide emphasis on improving surgical services. And the ministry developed the strategic plan, and in the national healthcare quality strategy also, it has identified some 5 focus areas, and one of them is improving the surgical care. So in order to accomplish this, the ministry has also organized a dedicated team in the Ministry of Health responsible for improving surgical services. And we have also, we are also now working on, the evaluation of the last 5 years strategic plan for surgical care. And we are also in the process of developing the next 5 years strategic plan for surgical care. And CleanCut is also a member of the technical working group established at the ministry, and we are more or less working closely to improve the surgical care in this country. And CleanCut has a role in supporting the ministry's strategies for improving the surgical service.
Thank you so much for those comments. I think what my observation is that the support that comes from the minister and the ministries and the people who represent the ministry is absolutely critically important inside the hospitals, the institutions that are actually trying to do this work. It makes the work easier to do. It makes it easier to get the resources that you need to be able to advance this kind of work. And so ministry support's absolutely critical. And I think it says something that CleanCut, just in the few years of its existence, has become part of the plan to make surgery safer across all of Ethiopia. So we have about 15 minutes left for some questions. I think one of the things that is on my notes here to remark on, though, is that Lifebox really stands with all of the healthcare providers around the globe who are helping the rest of us, because I'm on the patient side too, obviously, make it through this pandemic. And that Lifebox stands in solidarity with everyone else who is doing work that touches on the pandemic and the stress that it's going to place on the healthcare system, which is true in my own country, very, very as much as it is any place else around the globe right now. So I need to look at my WhatsApp apparently. And there's some questions. So I don't know who's going to be on the hook here, but. All right. It says you sent me questions, but I don't see them. Kitty?
Bill, maybe I'll Bill, it's Tom here. Maybe I'll jump in. There's a number of questions on the Q&A section. And so if it's all right, I'll start to parse through some of these questions. So the first question actually is one that we've struggled with that Nati and Nicole addressed a little bit. around the biggest barriers and behavior changes, and then also the buy-in that's needed from providers and hospitals involved. And the poster asks, was there a tipping point that made these behavior changes lasting and widely accepted? And so maybe I'm going to ask, actually, I'm going to ask Abebe as well to talk about, and Tito, to talk a little bit about some of the barriers and behavior changes that were necessary to overcome when implementing both in your own experience and also as you kind of worked with other hospitals. So maybe I'll start with Abebe and then go to Tito.
Thank you, Tom. I think it's a great question. In my experience, the greatest barrier to change in surgery is culture. Even if the data is in front of you, if the numbers are in front of you, if there's a certain way you're used to, that you're very comfortable with, changing to a new system is quite challenging. Surgeons and anesthetists nurses are bright people. They eventually do, they change, but it takes time. It takes leadership, persistence, and speaking in a language that all of us can understand. That has been the biggest challenge. The second is the same holds true for leadership. Leadership needs to see some results. The ministry needed to see some results. At the beginning, the medical directors and the CEOs needed some evidence. And this was the beauty of Clean Cut. Clean Cut had a 4 weeks situation analysis kind of stage where the surgical service is a kind of assessed. That's compiled into a result and then presented to the hospital leaders and the research team. And then the project was implemented. That, in my experience, had been the tipping point. When leaders and the surgical team saw those results and they realized such a finding exists in their hospital, they started to be open to the idea of change. And the last thing I can say is engagement, continuous engagement. I was from the Black Light at the Quran Bessa Hospital, and then I moved to the Menelik Hospital. My colleagues followed me. Dr. Nathaniel has been at his hospital. He's been the focal person in that specific hospital. Having those champions in these specific hospitals really helped in the success of the project. Thanks, Tom.
Thank you, Professor Abe. You already mentioned the challenge. So in addition to the leadership and also the culture, we have the lack of fine skill, specifically teamwork and team communication is a major challenge for us to break through and get into this kind of project. So having a champions in each hospital will help us to sustain and also clear out our initiatives or goals to all the team members and also to the leaders. So looking for that specific person might be the most important thing before the initiation of the project. So we have to look for that specific kind of person so that it will be helpful for us to continue or to expand our idea towards all the staff members in the hospital. And working on the team spirit, so in the ORs, especially the OR manager should take the responsibility of engaging all the staff members to be part of the teamwork for all the outcomes we deserve to have at the end of the implementation of the project. So having a focal person and having a good OR manager will help to cascade these things in our hospitals. And also additionally, making it as part of our work, if possible, during the training is also one of the things we have to plan for the future, but it is one of the things that is suggested by some of the members during the implementation of this project on our sites. Yeah.
Yeah, I think you both make really important points about that whole aspect of the team, the creation of a team, and the really ensuring that the team has ownership. And I think Nati brought this to to attention as well during some of his comments, that the idea of ownership of the program that's spread across numerous team members, and then that team working together has to identify barriers and then work to overcome them. It's something that Jared had mentioned through this process that we create within Clean Cut of process mapping, kind of really diving into why things aren't quite right, what the problem is, and inevitably, and Nati and Nicole and Tito and Abebe can all attest to this kind of concept that actually the answers exist within the facilities themselves. Frequently, numerous people already know where the problems are, but they never individually have enough power to make those changes. But when you start putting them together in a team and you give a team responsibility to make those changes, suddenly people feel like they have ownership, and then they can start making changes, and they have the protection and the support of all the other people that are part of that engagement. And I think that's really important. And that's why having the ministry involved and supportive, and having a hospital administration involved and supportive is a really fundamental part of the success of a program. Because otherwise it's a constant struggle, as Bill has mentioned. I want to ask, there's been a number of questions both in the chat and on the Q&A session about kind of expansion, what countries have been involved, what are the next sites, how to get involved more broadly. And maybe I'm gonna turn this actually to Senayat. So Seni, can you tell us a little bit, as your role kind of as East Africa, head of East Africa programs, you have to think a little bit more globally about how to go from from a number of facilities to a country to a region and beyond. And tell us a little bit about how you see expansion, and where do you think that the opportunities lie for kind of further spreading this kind of work?
Thank you, Tom. So to start with the opportunities where we see them, again, as you mentioned, my new position, taking the head of programs for East Africa, and also having Dr. Titenna as a global clinical lead for the whole of Lifebox programs, and having fellows in many countries. This shows us, and it can show a lot for others as well, that we are planning to go globally in the future, in the near future sense, in some Eastern African countries that we have requests from. And as Dr. Tetana mentioning earlier, some of the countries that we have been communicating for the past maybe a year or two, and we might be starting soon. But also the Clean Cut project might expand in some other Eastern African countries. And this also is, I can mention some of the interests and some of the steps that we're taking, having fellows in these specific countries that we have. If any one of the attendees can go to our website, they can get the application call for fellowship program as an international fellowship program in helping us to implement Clean Cut project, and more, not just Clean Cut, but also other projects that we have as a Lifebox in many other countries. So yes, we are expanding surely soon in Eastern African region, but also hopefully in other African region, and also in the Northern America, India, that we are going to take Clean Cut.
And I do want to mention that there has been some specific chat, especially in French and amongst the Francophone West African colleagues and attendees. And so there is absolutely a plan for translation of materials and of building out programs in the West Africa region as well. So I would like to certainly encourage further partnerships in Francophone West Africa, and also among Spanish-speaking countries, particularly in Central and South America. Bill, you looked like you had another question. Is there something that you wanted? Was there a question that you wanted to ask?
No. Actually, I appreciate. It's interesting. I don't moderate a ton, and the multitasking of it is actually driving me mad. So watching the chat and looking at the questions, and then trying to process what people are saying and pay attention, because there have been some incredible things said by our panelists, is quite a challenge. And I was a heart surgeon, used to things being thrown at me constantly from different directions. So no, I really appreciate you stepping up. And you've been scanning the questions. Are there any that people have had that have been touched on?
So I would say just for the attendees, if you under the Q&A session, there's both the questions and there's also answered questions. And I know that a number of people, I know that I see Jared and Nicole in particular, have answered a number of questions, very, very concrete questions related to some of the programs around how do you overcome barriers, how do you introduce, that kind of a fundamental question of how does one start a program. Then there's also some questions that are in the chat, particularly around, kind of expanding upon some of the clean cut ideas and concepts. And I would like to stress that, the clean cut is a very concrete and specific program that's focusing on 6 very, very specific compliance measures with surgical infection prevention. But in fact, the strategy that underlies it is one that's very simple in concept, but very difficult to implement. And it's really around, building teams, identifying problems in your workplace, and then working together to solve them. And so, for example, there was a question in the chat about not just the perioperative or the preoperative prophylactic antibiotics, but what do you do about antibiotics that are kind of routinely administered postoperatively for patients who don't necessarily need it as prophylaxis, and those kind of things have been a little bit beyond the scope of Clean Cut as a particular initiated project. But the lovely thing about the concept of the program is that the program can be expanded to include other aspects of infection prevention and surgery, whether it's infection prevention around specific to cesarean section, whether it's infection prevention specific to good antibiotic stewardship, whether it's infection prevention around how we do a better job of sterilizing and cleaning instruments. And so all of those things really can be encompassed in a very flexible program. And so we are always at Lifebox constantly looking for new partners to bring on board and engage with. We're getting close to the bottom of the hour and the end of this. Before I sum up, I do want to make one special mention and thank you to the Safe Surgery 2020 program, which was instrumental in funding this. To Sherry Reynolds from Assist, to the GE Foundation, who took a big chance on us at Lifebox in helping support a program that hadn't really been quite entirely developed, and then helping us shepherd a program from concept to implementation, initiation, and now to spread. And so it's very important to understand that it takes a lot of work from a lot of different people and the support of partners, not just locally, but internationally. I'm going to, let me stop there. Bill, maybe I'll turn it over to you for any last minute thoughts.
Yeah, yep. Thank you, Tom. The first thing I want to do is to thank all the panelists and all the attendees for your time, and to the panelists for all of your brilliant thoughts and your ease in expressing them over the last 90 minutes. It's been an amazing call. Tom, I think I heard when you were talking, you spent in just the last little bit, you spent a lot of time talking about infection control and infection prevention, and it is unbelievably important. But my guess is if I were to go around to the people who have implemented this in their facilities, they're learning quality improvement. And those techniques can be applied to solve any problem. We're not just around infection. It can fix supply chains. It can fix financial problems. It can fix any problem in the hospital, because Clean Cut teaches quality improvement. Measure something, have an aim, engage your team, all these very basic lessons. I teach a course in quality improvement. Actually, tomorrow's the first class, which I'm going to be teaching remotely at Harvard from here in San Diego. And you guys are giving the gift of teaching people how to be improvers. So everybody who's spoken on this call gets an improvement certificate, as far as I'm concerned, because you are all improvers and you're teaching other people how to think like an improver. That magic that you talked about, Nicole, all of a sudden people figure out, I can fix it, right? And this is the way that I do it. And Clean Cut has embodied that and given that gift to so many, many places. And that gift will change people's lives. It's already changed people's lives here. It will make them improvers, and they will make the healthcare system better without us, standing over their shoulder, because you taught them how. And you didn't even try. And to be honest with you, I'm not sure you even knew it. But, as an improver, I can tell you that's what you all are, every single one of you. You've turned into certified healthcare fixers. And I'm amazed and incredibly appreciative of all the work that you've done. So thank you, everybody. Thank you for spending the last hour and a half and a little bit with us. The call's been recorded, and the recordings will be available shortly. And they're available, it'll be available in multiple languages. A lot of work by a lot of people went into putting this call together, and I want to thank all of them too. It's been an incredible experience for me and an incredible privilege to spend time with all of you guys. So, all right, Kitty, are we done?
We are. Thanks so much, everybody.
All right.
Thanks, everyone.
Thank you.
Thank you, everybody.
Have a good day.